things that are right now, and we'll go from there.
All right, great. Moving on to the laboratory studies. The remarkable ones, I'm going to skip over the normal ones. So carbon dioxide was 37. BUN was 30. Creatinine 1.5. Baseline is 0.82. Hemoglobin 8.7. And the white count is 5.34. COVID is negative. And I'll stop there to see if this helps you in any way. ProBNP, let me also give you that. It was about 1,000. Oh, and troponin was normal.
Thanks for just giving us the positive pertinence, because I tend to get overwhelmed when there's a lot of labs thrown at me. So actually, oops, rapid response. Why don't I mute myself and let Travis talk? I'm in the hospital right now.
Yeah. So just going from his labs, he's got a normal white blood cell count, but that doesn't really tell us much. I mean, maybe his baseline white blood cell count is 3. And I was told, making a decision on whether someone with a normal white cell count has an infection, the white blood cell count is the last resort of the intellectually destitute. So that's what they used to tell me and say, hey, their white count's normal. And that does not mean that they do not have an infection. So an infection can still be in play, especially if he has a large bandemia and it's neutrophil predominant. I mean, that might give you a little bit of a whiff that there might be something inflammatory going on. His hemoglobin of 8.7. Yes, that's a Greg Henry quote. Yep. His hemoglobin of 8.7. Ravi, did you say that is his baseline, or we're not sure?
I'm not sure, but definitely is low.
This means one of two things. Either one, he has acute blood loss, either he's, losing it somewhere, or he's hemolyzing, or he has, anemia of chronic disease, and maybe there's some kind of medical condition that he hasn't been treated for, and he's had, anemia for a long period of time. So I don't know how much that, I'm going to use that right now to maybe get to my ultimate diagnosis. But I'm definitely thinking about it and wondering if, I should ask him more questions about blood loss. Does he have melena? Has he ever had this before? And I'm thinking of maybe adding maybe a retic count or an LDH or a haptoglobin on to his labs. The platelet count you didn't give. I don't know why you didn't give it. Maybe it's for some reason, because maybe it's really abnormal and it has something to do with his low hemoglobin.
Normal 191.
191. Okay,
Yeah.
Good. So normal platelet count, I'm thinking, maybe, sometimes it can help you if it's high, if it's an acute phase reactant, or if you had iron deficiency anemia, it could be high, but it's normal. And then kind of going through his sodium, potassium, probably normal, but his bicarb of 37, that tells me he's a CO2 retainer. So like just confirms that this guy's got, COPD and is likely a CO2 retainer. He's got a BUN creatinine ratio that's high. His creatinine's elevated, it's dry. He's got either acute kidney injury, whether it's pre-renal, intrarenal, or post-renal. More likely, given the situation, it's probably something, intrarenal or pre-renal. Certainly, would want to give this guy, think about giving him IV fluids, but he kind of maybe looks a little volume overloaded, considering his elevated pro-BNP of 1,000. And let me think, COVID negative, which is good. But so I guess my takeaway from this is this guy he's probably volume overloaded. Okay. And his pulmonary findings suggest that he probably has bilateral effusions that we'll see, and he probably has tons of V lines everywhere on there. So there, something is affecting the heart. whether it's a heart valve problem. I think, a POCUS or getting a formal echo will help. But that's my interpretation on that. I don't know, Ria, if you have any what other great things you have to add to this, because I'm sure you probably can.
I don't know that I don't have a lot of great things to add to this. I do have some clarifying questions. So we have a hemoglobin of 8.7. I don't know if you said what the MCV was on that. Maybe you did.
I'll give that to you. MCV was 90.1.
90.1. Okay. And you said that he has a baseline hemoglobin that is normal.
Higher than this, I think in the 10, 11. I don't have the number, but I know
10,
definitely it's higher. Yeah.
Okay. I mean, whatever we're thinking, it has to take into account the fact that he's got anemia. So now, on the this doesn't really give me any more clarity, because of the dyspnea pyramid. At the top of the dyspnea pyramid is the other forms of dyspnea, and anemia is on there, which he has, right? I think the imaging is going to be important. I don't know that we talked too much about the diastolic murmur and rumble. Diastolic murmur rumble on the left sternal border tells me there's something maybe wrong either with the tricuspid valve more than the mitral valve. And we're either talking about a stenosis of the mitral or a regurgitation maybe of the aortic valve. Is that new? Does he have a new valvulopathy? Again, we talked about, is this an endocarditis type of a picture? But I, again, don't have a whole lot of extra clarity now.
Oh, that's superb. Yeah. So that murmur definitely was something that was new and was sort of challenging to try and interpret. But I'm going to give the POCUS images. But just for those that are watching on YouTube, we started recording late. I'm just going to give a summary so they can catch up. So we have a 72-year-old with a past medical history of COPD and hypertension who comes in for dyspnea, worsening cough for 3 days. There's some chest pain, some subjective fevers, had been treated with antibiotics previously, felt slightly better, but comes in and is quite hypoxic with being on 4 liters nasal cannula. And on the exam, we find no JVP, thin elderly male, and there's some respiratory distress with decreased breath sounds at the bases and diffuse rales. And also has this diastolic murmur rumble, which is new. And on labs, significant findings, there's a new kidney injury, carbon dioxide is chronically elevated, and there's a normocytic anemia. And COVID is negative, troponin normal, EKG shows sinus tachycardia, and proBNP is also elevated. So now I'm going to shift to the POCUS images, and I'll share screen. And then I'll have both Travis and Ria then take turns to try and interpret. Some of these, I didn't have the POCUS images, but I just snagged them off previous images just to demonstrate the findings that this patient had. You may have to stop. Okay. And do you see the POCUS images?
Yes, we do.
Okay. So this is the upper lung fields. Do you want me to stop? Anybody want to tackle this?
It's the, can I do the easy one?
Yeah.
Those are beautiful beelines. So, this is something on POCUS that we'll see commonly in patients who present with, an acute CHF exacerbation, or depending on, if you see this diffuse everywhere, it could be multifocal pneumonia. I mean, if you're doing POCUS on, depending on where it's at, but that's telling us that there is fluid there, and there's reverberation. You can see a little A line there at the top, but there's something in the lung. It's either pus, water, or blood, that's giving that reverberation artifact. And I think on the top they call it now the ants marching thing is more for like a lung sliding, but those are B lines. I don't see any good A lines. So there's fluid in this segment of lung that you're imaging.
Oh, sorry. I think when I was recording, there was some background noise, but you want to take a look at this one too? Let me decrease.
I mean, this is even easier, Dr. Smith, because it says large right pleural effusion. you chose the wrong one. And I just wanted to comment that Travis is spot on with the B lines. That's some interstitial pathology, and most typically base rate is probably edema, and then in the right clinical context, maybe a viral pneumonia can look like that as well. Where I have gotten tricked in the past, and I want everyone to not be tricked by this, is interstitial fibrosis can also cause B lines. And so I always keep that in the back of my mind, especially in somebody who's inhaled heroin. Does he have sort of a baseline B line pattern anyway, because he has interstitial fibrosis? And that's something that, again, something to think about. We said on the physical exam where he had absent breath sounds or decreased breath sounds bilaterally, that probably an effusion is causing that. This is a really large effusion. So on the right side of the screen, you'll see the diaphragm, which is that large echogenic structure that kind of comes off of the screen. And then under that is the liver. So we'll let it scroll again. There's the liver, since we're on the right side, right? And then just above that, so anything to the left of that on the screen is by convention in the thoracic cavity. And if it's black, it's fluid, is a general rule. So that looks like fluid that doesn't look like it has any septations in there or loculations. It looks mostly simple to me. Maybe there's some signal sort of on the far end. I never know whether that's, just a far field issue or if it's truly signal making this not completely anechoic. And then the big jellyfish looking thing is his atelectatic lung. So the other pearl here is this depth is probably more than 10 centimeters from the chest wall to the bottom of the image. So we've got more than a liter of fluid here, and he is badly in need of a needle to give us some diagnostic clarity and probably make him feel better, honestly.
Yeah.
I would guess he has 2 liters maybe of fluid in there.
Yeah, he had a similar, maybe less than this on the other side as well. So both that accounts for the diminished breath sounds at the bases on the exam. And if we were to percuss, we would have had the typical dullness to percussion as well. That was pretty high up in the chest. The next image is subcostal 4-chamber view. Anybody want to take a stab at this?
I will take a stab, but I see some abnormality in is that the left atrium?
Yep.
Okay. I see a mass in the left atrium. That's a thrombus. It's, I don't know if a bacterial, a bacterial thrombi can get that large, but there's something there that is not normal. And I probably would have some skilled echo tech come in and get a full image, but that is definitely not normal. That's likely what was causing the murmur and probably what's pushing this patient into pulmonary edema. And we all talk about pivot points, and I think that's the pivot point right here, is finding that, because a lot of things can cause pleural effusions, and as far as what this is, I'm leaning more towards this being endocarditis versus, gosh, I don't know if a procalcitonin would help, but I don't know. CT surgeon to come and evaluate. As far as like going from here in management, I think the management's probably going to be the same. No matter what it is, this person probably needs an aggressive diuresis, a thoracentesis. So, I mean, he's going to get Lasix, whether he needs a high flow or BiPAP, I'm going to keep him on that to keep his oxygen, saturation above, 92 to 94%. And whether or not we need to do maybe a CT scan of his chest to see if there's any emboli in his lungs. Maybe he's got septic emboli too. I think that'll help. Adding on procalcitonin and blood cultures, and then going from there. I'm curious to see what you think of this, Ria.
Right. Your first thought is, oh, that's bad. But just looking at this systematically, someone also said, is that a PA catheter in the right heart? So the chambers that are closest to your probe in a subcostal 4-chamber view are the right atrium and right ventricle. And someone astutely picked up that there is a linear hypoechoic structure that's going from the right atrium into the right ventricle. That probably just speaks to the fact that this patient is sick. And people are already doing things. We talked about this on physical exam, what we heard, and is there some mitral pathology here? There's definitely some mitral pathology here, right? I think what's also interesting to me is what I was wondering is, there seemed to be something blocking. If it was true that we had lots of pleural effusion, big pleural effusions and B lines in the lungs, and there's something blocking fluid from going into the lungs more so than there is stuff or something blocking blood from entering the right heart, right? Because if you had a lot of right heart failure, you would think the edema would probably be worse. And they would have, maybe some congestive hepatopathy, et cetera, et cetera. So this is solidly a left heart problem, and now we see why there's solidly a left heart problem. The tension that I'm trying to figure out is he presented with 3 days of symptoms, which is pretty acute. Whatever this is, so it tells us a little bit about what this must be. So atrial myxomas don't, in my mind, seem to be something that grows in 3 days to the point where it causes a problem like this. Although I think an atrial myxoma is probably the most common thing that we would see a big bleb like this. Certainly if it were a thrombus, again, the thrombus generally forms on the right side of the system, and it end up in the pulmonary, as a pulmonary embolism, right? And this is solidly in the left side. So that's the issue. What formed over 3 days in the left side of the heart? So honestly, I would go and see if this man has a prior echo that can help me sort of figure out if this is something that was maybe known. Parasternal short at the level of the aorta and left atrium.
Yeah, here's another view.
This is the same thing. Yeah.
Yeah, same thing. Yeah. So I'll stop sharing there, and I'll give you some more data.
I would ask his wife. I bet I would ask his wife. The patient's probably, this is how men are. Men wait until the last second before they come in.
It has to be really, really bad, right?
Yeah, it has to be really, really bad. And usually you talk to the wife, you say, no, sir, let me talk to your wife. And the wife's like, no, he's been short of breath for however long. He's been complaining of these things. And that's usually what brings them in. So I first would go ask the wife. But could you imagine not doing a POCUS on this person? And you're like, hey, this guy's got heart failure. You diurese him, you get an x-ray, you don't see this. I mean, you could completely miss that. And sometimes it's hard to hear heart sounds. And maybe you just listened to him. And while you were listening to him, he was talking, so you didn't get a good listen to hear that diastolic rumble. I mean, I can so see how this would get missed.
He's a farmer. Yeah. If a farmer comes in through the ED, just go ahead and activate all of the ICUs. So I still would definitely stick a needle in that effusion again, because are we thinking infection? Is this a ginormous endocarditis? Are we thinking this is a malignancy? The fluid, I think, would help us.
Yeah. So, next bit of data, the CT, definitely we're thinking PE, possibly endocarditis and so on. CTP showed cystic bronchiectasis with superimposed consolidation in the right lung. There's adenopathy noted within the mediastinum. And a TTE showed large mobile mass seen in the left atrium. It is attached to the intraatrial septum, and that makes it very suggestive of myxoma. LV function was grossly normal, and a CTA was suggested, and that showed that 5 by 5 cm hypodense, mildly enhancing mass that's adherent to the inner wall of the left atrium fills 80% of the lumen of the atrium, 80 to 90%, and likely a myxoma. And then it also notes that there's some consolidation and effusions and congestion in the lung. So this patient was then seen by cardiothoracic surgery, and then they decided to see the patient, and unfortunately, patient left against medical advice. And after that, we're not sure what quite happened. We kind of have to do a search around the city to see where the patient ended up. But the patient did feel better with diuresis and thoracentesis, and I think because we're feeling better, and then with this new diagnosis, we're very concerned and wanted to seek another opinion.
And was the pleural fluid helpful diagnostically?
Oh,
Or helped it
transudative.
feel better?
Yeah, it was therapeutic and diagnostic, so it did make him feel better. And I guess looking back at, I mean, I've never seen or heard of a case of a myxoma before, but like Travis had mentioned, like you don't necessarily come in with JVP and the signs, maybe some signs of congestive heart failure, but it can be very silent and creep up and grow slowly until it develops into this obstructing lesion, which can then manifest with, like Ria had mentioned, left-sided heart failure. There were some signs there, subjective fevers you can have, night sweats, things like that, because it is a malignancy. So there were some of those features there as well. Any reflections?
This guy, he doesn't fit into the box of, myxomas usually are more common in women, by about 2 to 1, and they present, I think, in the 4th to 6th decades. So, he doesn't fit that mold. It does fit, 75% of them are in that kind of intra-atrial septal region versus, just in the atrium or close to the ventricle. So, I mean, it does meet, as far as commonalities, but, it's crazy to think these things can get like 15 centimeters big in some of them. So, I mean, who knows how long it's been there. And, maybe he had symptoms that he was prior to this, that he was just chalking up to his COPD. Oh, I'm a little bit more short of breath. I can't do what he normally does. He's 70 and he's a smoker. And, that 7th decade is definitely when people's exercise capacity, and things just really drop off. So maybe he was chalking it up to age. So I'm sure he's been symptomatic for a while. And then, you get that tipping point where, there's something that changes his physiology that really makes him symptomatic. And he all of a sudden, goes into, gets pulmonary edema and pleural effusions, causing him to come in. But I mean, that was a great case. And, maybe that's why, I don't know, the hemoglobin of 8.7, did you ever get any sense on if that was more of a chronic issue or?
Yeah, it looked like chronic, but before we really got to do any further work, the patient left.
Good case.
I hope sorry, go ahead.
I was saying it was a good case. What are your reflections from this, Ria?
That's probably the hardest part for me to kind of say on the fly, because generally it takes me a while to kind of go back and reflect. I think that what I was trying to do was because I'm weak in physical exam, admittedly, trying to figure out on physical exam. And I did have help here with 2 other MedPeds hospitalists, Dr. Aaron Finn and Dr. Will Kwan, especially with the heart exam. So an exercise that I personally tried to do, and I would encourage everyone to do, is use their physical exam to try to predict what their POCUS exam is going to show them. So none of that was super, it didn't come out of the blue to know that there was a big pleural effusion there, and that we saw some B lines, and we kind of predicted those things. A myxoma is one of those things that will get you into POCUS. the things that we like to call our first kisses, big atrial myxomas, a pericardial effusion that is causing tamponade, those things that are just like, wow, I would never have seen this, this diagnostic journey would have been so much longer had I not brought an ultrasound to the bedside.
Awesome. Yeah, absolutely great reflections there. Yeah. We're going to have teaching points now. Leah, are you able to take it away?
Yes, I had some problems with my connection, but I hope it's working now.
It's working great. Thanks.
Thank you for presenting this case. I think it showed again, I think I love your reflection in the end, Ria, that shows how you can try to guess or figure things out, but certainty you will only get when you actually have the imaging. So we actually started off by also having some reflections on history taking in general, where we thought that it might be helpful to ask previous caretakers of the patient whether they have some more information on how fast this patient got worse, were there any triggers, any more information about the evolution. Then Ria mentioned the Dyspnea Pyramid, where the basis is built by the lung, then cardiac causes, and then more rare causes like anemia or metabolic acidosis can also be a cause of shortness of breath. We had the nice extension to the I made mnemonic by making it I made it for T being thrombosis, also by Ria, which I found was really cool. And then we have some indications because this patient on the lab had an elevated bicarb, which is explained by his chronic hypoxemia, which he has due to his COPD. And another thing we can look out for is polyglobuli as a sign of chronic hypoxemia, which was not here in this case, but in general, that can be an indication. And then we talked about the B lines in lung ultrasound, which represent fluid collections and can be present in pneumonia or acute heart failure. And we should also be aware that interstitial fibrosis might falsely mimic the same pathologies. And then we saw a POCUS image of a pleural effusion, where we had this jellyfish kind of lung floating in the anechoic fluid, and the diaphragm separating it. It was really nice to see that on this image. And finally, we saw that there was a mass within the atrium, and we thought about differentials like a thrombosis or maybe some kind of neoplasm, which it turned out to be in the end, it was a myxoma, and was also a new learning point for me that myxomas, even though I believe they are benign in the sense that they're not invasive or metastatic, they can still present with night sweats and severe systemic symptoms like this, especially also due to congestion if their mechanical obstruction has effects on the system. So yes, thank you for discussing this case, sharing your reflections, and thank you for the case, Ravi.
Great teaching points there, Leah. And thank you, Dr. Dancel, Dr. Smith. Wonderful discussion. Thanks, everybody, for coming today. See you tomorrow. Have a great Tuesday. Take care.
Bye, everybody.
Bye.
Bye all.